it?
2 minutes. Exciting.
Cool. Good evening, everyone.
Just 1 second. One
Oh,
second.
no.
2 minutes. Exciting. So, yes, good evening, everyone, and welcome to Medical Mondays with Dr. O. I'm Toyin Okpesomi. I'm a family practitioner, HIV specialist, and I treat addictions in Maryland. I also host Medical Mondays with Dr. O, and I'm always excited to be here because I learned something, not something. I learn many things every Monday. And it's Men's Health Month this month, and we've decided to dedicate the month to men, except for that first week when I didn't realize it. So we have the honor of having our very own Dr. Ifeanyi Olele here tonight to share with us a subject that we shy away from in our culture, a subject that has, you know, I don't know, this horrible stigma that it shouldn't have and have people suffering for the rest of their lives because they're not getting simple intervention. Dr. Olele is going to help us tonight to understand major depressive disorder. And I love that title, Feeling the Blues. Are you feeling the blues? You got to be honest with yourself tonight. You know, we're a family and we are always real. So, without any much ado, I'm going to yield the floor to Dr. Olele to complete his introduction and, take it and roll with it. Welcome, Doc, and thank you so much. I also want to thank Um, our Dr. OK from last week, who introduced Dr. Olele to me. Thank you so much. The floor is yours.
Thank you. All right. Good evening or good morning. I don't know where everybody's at, but yeah, my name is Dr. Ifeanyi Olele. I treat patients in the DC, Maryland, Virginia area, and today I'm in my Fairfax, Virginia office today, and I'm a board certified psychiatrist, and I'm very passionate about mental health and how mental health shows up in our communities. So during this presentation, I'm going to give you basic understanding of what major depressive disorder is, and hopefully we have time to engage in a full discussion. All right, so we'll begin. So feeling the blues, we're understanding major depressive disorder. As we know, or you may not know, depression affects millions worldwide, yet it remains widely misunderstood. So, our goal for us is to understand these realities of how major depressive disorder can impact you or a loved one. Okay. What is major depressive disorder? It is classified as a mood disorder with persistent sadness and loss of interest in your daily activities, and is characterized by this common mental health condition. It's very prevalent. Most mental health disorders in the United States, we see this, whereas about 12% of the people get impacted of it during their lifetime. It interferes with daily functioning, relationships, and quality of life. And when left untreated, it can have catastrophic effects. And so in the United States, it's one of the reasons why a lot of people may file for disability because of the fact that their lives are impacted and impaired in their functioning. So one of the things we're going to look at is recognizing the symptoms of major depressive disorder. So couple things, emotional changes. I'm looking for a patient that comes to my office and says, yes, I have persistent sadness. I feel that this feeling of empty or this hole in me. I'm hopeless. I'm worthless. That's what a person with major depressive disorder may be feeling. And one of the things we can notice is they're irritable, angry, agitated and it's just lasting most of the day. And then for loss of interest, this could this could be a person experiencing lower levels of pleasure in activities they enjoy doing, such as basketball, playing soccer, football, or spending time with their family. And with this, we notice, especially with depression, the person reduces their time with their hobbies and their activities. They're not going to as much social events or their meeting groups in the community, or even having sex with their partner. So this is a telltale sign of uh, major depressive disorder. And then when we're looking at it physically, depression can impact you that way too. We notice patients have sleep disturbances, meaning that they're sleeping too much or sleeping less because of the depression. The patient may come to me and say, Doc, I'm experiencing a lot of fatigue, low energy. And then they talk about weight changes. Either they're gaining too much weight or they're losing weight because they're so depressed they can't even eat. So that's why when they come to my office, I always like to know what they're eating. Are they introducing new foods, or have they backed off their favorite meal too? So that's very important. And then also, if they're having unexplained pain, because some people could feel their pain like, oh, I feel sore all over my body. I feel this chest tightness. So that is something that I do look at. And in regards to the cognitive impact of depression, patients may complain of trouble concentrating, they're stuck in their decisions, they're feeling guilt, and the most troubling is the thoughts of death. And this is where, as a provider, when they're talking about thoughts of death, I want to know if they're trying to uh, die by suicide. I always want to know if they're making any rehearsals, plans, attempts because of those thoughts of death. And this could be their mortality where they kill themselves because of depression. With depression, there's different levels that we all should look out for. And this is definitely our emotional well-being tracker. So here are some patterns and the severity of depressive episodes. A mild depressive disorder, a person may have some symptoms with minimal functional impairment. Their daily activities remain, but there's a possibility it may require more effort and more energy to get things done. Number two, some people may experience moderate depression. So they're going to be experiencing more symptoms present with noticeable functional impairment. And again, the daily activities that we're talking about, such as going to work, brushing your teeth, taking a shower, may become increasingly difficult. Number three, severe depression. Here, the most symptoms are present, the symptoms we talked in the last slide, but with significant functional impairment. And this becomes impossible without help. So this might be a person where you see them staying in bed all day. They're calling out sick to work a lot. They're not able to take care of their kids, their family, and it's just everything about them is very dark and their mood. So an episode could be very single or recurrent multiple times in their life. So this is something where I, as a provider, when I'm talking to my patient, I want to know, okay, is this just a one-time thing? This is something that just occurred a few months ago and is continuing now? Or is it something that you've experienced in the past where you've had a depressive episode in high school, you had another one right out of college, one where you moved to United States or whatever. So now it becomes recurrent because they keep having episodes of depression. And like the slide says, some people may experience seasonal patterns or depression alternating with mania, better known as bipolar disorder. So with men, depression in men, this is a very hidden struggle because of different ways that we were brought up and the way we look at ourselves and we feel the community looks at us. And so some of the hidden symptoms that many men may experience with in regards to depression, anger and irritability instead of sadness. So they're shouting, they're angry with their wife, their kids, their coworkers. They're engaging in maybe some risk-taking behavior, increasing substance use, possibly because the substance use increase may be for self-medication. So that's a possibility. Then they could find themselves where they are physical complaints rather than emotional ones, working excessively long hours. So that might be some things we're looking at. And it could also possibly be like bipolar depression too. So some of these symptoms. So we have to keep an eye out on this, what this man may be silently struggling with. And so it's important to know men are less likely to seek professional help. Men may have higher rates of substance abuse than women, and more 3 to 4 times the higher suicide rate compared to women. And men go significantly undiagnosed because they're not going to get evaluated by a provider because of stigma and shame. So as June is Men's Health Month, which is very important because the men, we are somebody's father, brother, son, cousin. So we all play a role in our families. And it's important to take our health seriously because our health is our wealth. And without it, you're significantly impaired. So June is a very focused month, highlighting the physical and mental health issues impacting men, especially depression. There's definitely across the country with this Men's Health Month, there's been different types of screening initiatives for helping men um, detect health concerns like cancer screenings, like asthma screenings, weight screenings. And with depression, we do have rating scales, which we do to help screen men for depression. It's called the Patient Health Questionnaire, better known as PHQ-9. And one of the things that I love about this Men's Health Awareness Month is open dialogue, where men could be among their community and have open dialogues where they could discuss what's going on in their life without being judged. It's a safe zone. And so whenever a person comes to my practice, I always tell them, this room we're in is a safe space. There's no judgment. I'm here to serve you. And if there's something that you don't want to elaborate on, you don't have to. We're meeting each other for the first time. So it's important for men to be proactive in their mental health because it's time. And we could be the leaders for the next generation to allow them to be vulnerable and share what's going on and not carry this silent pain because you're feared that the local men in your community will see you as weak, or they'll may say, oh, he doesn't have it together, why come up to him? But you could be a brother to this man, or you could be an advocate for him to help him say, hey, I know this therapist who could help you, who's very culturally sensitive to our issues. So you could go to him and you won't feel like you are alone, and you won't feel like you are a nuisance, but definitely please get help. So this is a very powerful statement, stigma in the African community. We could be our best advocates because we love ourselves, we love our people, but we could also be the enemy to our people where we could shame them for asking for help. So a couple of things that we do see in our culture is the barriers. Traditional beliefs may view mental illness as spiritual weakness. You're not trusting God. They're like, why don't you pray? You're not praying enough. God, God helps them who helps themselves, or some quote we always say to each other. Um, so that's could be there. And so we look at that as a flaw and not a mental condition. Then there's strength. We, as Africans, we do have so much pride in our resilience. And if somebody's admitting to mental health or not feeling strong enough mentally or emotionally, they may feel like, oh, the community may laugh at me, or they may say, oh, they're laughing at me because I went to a therapist, and so I'm the butt of jokes. So that's where a person could view themselves for just even saying, even in their meeting group, when they meet their people, saying that, yeah, I'm struggling with depression. Then there's, again, community perceptions, fear of being labeled crazy or bringing shame to the family, because that's one thing I can't say about Africans. Family means everything, family over everything. And our family is our rock, and your name matters, and your family last name matters a lot. And so if it comes out or whatnot that somebody is struggling with something, they may fear that it's impacting their father, the mother, and the whole family. And then they're going to have that speculation. Oh, what are people going to think about our family? Are they thinking that we didn't provide for you? We did not give you food, shelter. We didn't put you in good schooling. Why are you depressed? You're in the United States. You're in Europe. You're in Canada. Why are you depressed? You're in a good back home. You're in a good home. We give you everything. Why are you depressed? So that is definitely something, a stigma. And then access issues, historical in the United States per se. I'll say this. I can't say in other regions, but there's sometimes a historical mistrust of healthcare systems and limited culturally competent care, which is now creating additional barriers. So ways for us to address the stigma and community insights, some effective approaches will be culturally tailored education campaigns, strictly for, it could be for Africans, West Africans, East, whatever, but, or the continent members or people here in the United States, Europe, and the Middle East, where it's focused based on their community. So that person could feel like it's addressing them. So that's important. Then community-based mental health resources, knowing where to go. Like here, I always tell my patients, go to the National Alliance of Mental Illness, better known as NAMI. And I always direct them to NAMI.org as a way to get local and community-based information because it's free. And so that's good. Engage in religious leaders as mental health advocates. So this is very important for the pastors in the churches, because the pastor has the command of his church and congregation. If the pastor makes it an initiative of mental health being a priority just as physical health, this could have a powerful impact, because the pastor is the foundation of that church. And when he says, let's make this initiative, let's pray for our brothers and sisters who are struggling with depression, it makes that person feel good. And he may call them up to the congregation, let's pray for you. That is powerful when the leader of your church could acknowledge that and say that we're praying for you, but also we're going to give you good resources. So that's beautiful. And then more representation of healthcare providers such as myself, Dr. O, where we are here, we're talking about this, and you could see somebody like, you'll say, oh, that's my brother right there. He's Nigerian or African or whatever, and I could feel I could maybe come to him or just ask him for guidance or who he could send me to. So it's good for representation. And all of this will do is addressing stigmas will bring awareness, create dialogue, and allow for support. So here are some treatment options, and I'm going to say this, not everybody has the same type of treatment. Reason being, we're all different, unique human beings. We've all grew up in different environments. We all have different genetics. So what may impact me may not impact you. So it's not like the saying they say, not one size fits all. So that's the way I look at treatment options for my patients. So one of the key things is self-care. So we do look at self-care as a very good treatment where a person is getting good exercise, they're having good sleep hygiene meaning that your room may be cool or warm the way you like it. You have a good mattress, a good pillow. Um, I always tell my patients, because we're all adults in this room, so the bed should be for only sex and sleep. So don't try to do work on your bed because that can disrupt your sleep. So just leave it for those two things. Then also nutrition, making sure that you are eating you're adequately, you're drinking fluids, staying hydrating, and stress management because you're dealing with the stressors of your work, then your children, you're in a partnership with your spouse, your wife, since we're talking about men's health, your spouse, then also you are dealing with parents who are getting older. So maybe you're in abroad and you have family back home in Africa, so you need to probably send stuff back home to support them, or you're putting somebody through school, so back home. So there's a lot of stress there, and so it's important for you to take a grasp of how you're managing that. So that's very important. Then next is psychotherapy. I'm a big believer in this, and I provide some psychotherapy in my practice. It's what we call like talk therapy, where a person goes, sees a trained mental health provider, and in this environment, they're just talking, and the provider is guiding this person through different aspects of their thoughts, the way they see a situation, and it's very important. And there's different aspects of therapy, such as family therapy, where it could be you and your whole family seeing a therapist. There's couples therapy, where the partners, the spouses together, are, you know, wife, husband, or husband, wife, whatever the formulation of the marriage. They're seeing a couples therapist who's working solely on that couple. And I do see a lot of um, African men. I mean, I'm not gonna make a general statement, but just more, or even immigrant men, even where the wife wants to go into couples therapy, but a lot of times the man is the one that doesn't want to be pulled into it because he doesn't want to be seen as the problem, or he may feel that he might be ganged up on, where that the wife and the therapist that she picked out are attacking him. But I always feel that it's very important, even for us African men, to go with our spouse to couples therapy to work on things, because when you're in therapy, what comes out is a lot of stuff that transpired in your childhood. Because a lot of us men, a lot of our the little boys are still in us. That boy that was hurt, or who felt ashamed, or who felt emotional barriers, is still stuck in this man, even if he's in his 40s, 50s, 60s, 70s. So that's psychotherapy is very important. Medication, where using antidepressants and other psychiatric medications to address the depression, which is FDA approved. And then we have advanced treatments for depression, are more interventional basis, such as transcranial magnetic stimulation and electroconvulsive therapy. And with all of this here, all of these treatments can be combined with each other. So it's not you pick one and go. You could have self-care, psychotherapy, medication management, and the advanced treatment. So therapy types and benefits. We have here cognitive behavioral therapy, better known as CBT. It focuses on identifying and changing negative thought patterns. And this is very important because a lot of us men may have negative thought patterns. And so the CBT is going to help you with coping skills for managing your symptoms. So you may have 12 to 20 weekly sessions, or you might just have the sessions for an extended period of time or your life with your therapist because you find that it's very valuable. And that's why I'm a big advocate of going to a culturally sensitive therapist. And even if they're not African or whatnot, but when you come there, the person understands the life of a therapist. I mean, life of an immigrant, first generation, somebody that just came from Africa to their new current situation where they live now. That therapist has an understanding of immigrant issues, and so you'll feel comfortable speaking to them. So they don't have to be an African therapist, but somebody that's culturally competent. And they'll give you homework during these therapy sessions to reinforce the skills that you learned. Then there's interpersonal therapy where you address relationship issues and social functioning that may be leading to depression, because some people can struggle with relationships or how they communicate with others. So that could sometimes be a blind spot for a lot of men. And that's why they may be asking, why am I not getting promoted? Why is everybody in my job not doesn't like me? And then the therapist say, you may be the way you approach them, you talk to them, you may be saying things in a way that is very rude to them and they don't understand. So this is a way to understand it. And again, make sure the person you're talking to is culturally sensitive because so that way they can help you out. And then there's support groups where you go to a support group where you're able to talk with people that are going through your similar situation. And the reason why I love support groups because there might be somebody that is very experienced in that problem. They've went through it in their life. There may be somebody that might have the same level of depression as you, or there might be somebody that is entering a depression and you're there to, and with all these people with different stages of being in depression or overcoming it, it's very powerful to be in that support group because you are pretty much getting practical life, and then each person's story could impact you, and your story could help others as well. So medications, which are the antidepressants that myself and my colleagues prescribe. Some common types you may have heard, such as Prozac, Zoloft, Lexapro. These are just brand names, but their generic names are fluoxetine, sertraline, escitalopram. We have Cymbalta, Effexor, which are SNRIs, serotonin, norepinephrine reuptake inhibitors, and better known as duloxetine and venlafaxine. Then we have different types of antidepressants such as bupropion. And there's also new ones in the market such as Auvelity. So these are, there's plenty of options to see to help out our patients. And then there's tricyclics. Then we have some important things to discuss when I do talk to patients. I do tell them that it may take 4 to 6 weeks for the medication to work. So that is a possibility. We have to look at side effects as a possibility. I always have to give the risk and benefits of taking the antidepressant. I may say, yeah, the medication may cause headaches, may cause insomnia, may cause low libido, may cause upset stomach. Then we have to weigh the pros and cons, but this is with guidance and education. It can help ease the anxiety about taking the medication. And we always say don't stop the medication abruptly because you could possibly get withdrawal depending on the level of strength of medication you're taking. And this is what thing that I always tell patients. And some patients may say, I don't want to be a guinea pig. I don't want to be a lab rat. But I tell them you're not a lab rat because the medication that we are prescribing, we're looking at the way your body breaks down the medications called like metabolism, because some patients may have metabolized or break down a medication very slowly, that this medication may be too much in their system versus a medication that may just go quickly, and they'll say, doctor, it's like I'm not feeling this medicine. So that's a big thing with metabolism. And then in regards to looking at this medication, we also want to see if this person has the right drug targets, because sometimes if you're giving a person the medication, they may not have the right receptors or targets. And so it's like they're not taking the medicine as well. So everything is trial and error. And until we find a medicine that's appropriate for you, we're going to do that. And I always tell my patients, please be patient with me, because I am trying to find the best medication based off your symptoms. And it's going to be difficult for us to get find one. But we may hit the jackpot on the first try. But if we don't, we always have options to look at. And it may be frustrating because you're like, I'm dealing with this depression and I'm trying medicine after medicine. But this is important where you talk with the doctor about this, and the doctor will try to customize a plan for you. And then the advanced treatments that I was talking about, we do have one called TMS, and I'll just, because I'm in my office today, well, I'll just show you what a TMS machine looks like real quick. So we have here, this is my TMS machine right here, where I do transcranial magnetic stimulation. I think you guys can see. So with the TMS, this is an FDA approved treatment for depression. And you may say, oh yeah, when do I start doing TMS? And when we start doing TMS is when a, a patient has failed about 2 to 4 medications, but this is all based off their insurance. So the insurance sets these requirements. And after failing 2 to 4 medications and doing a year of therapy at least, then the patient comes to me with due to treatment-resistant depression. And in this moment, once I've screened the patient and they're a good candidate, we'll do the treatment. And the depression is on the left side of the brain. That's where we're doing the treatment. And the dorsal lateral prefrontal cortex, that's where I'm administering the treatment, because that's the part of the brain that regulates the mood. And so I'm using magnetic pulses to stimulate the nerve cells in the brain region controlling the mood. And that's where we're looking for this term called neuroplasticity, where because our brain is always adapting. So this is an FDA approved treatment, is not quackery or anything. So we're not selling you snake oil. It's legit. And I have patients that are doing very well on it. And the patient comes in and they're not they could come in, get the treatment and walk and go to work, or go home, go on a date if they have one right after treatment, go play basketball. So the treatment is usually less than 19 minutes. And so it's very effective and I love it. And then there's electric convulsive therapy, better known as ECT. I don't provide that services, but I have recommended my patients for it. And what happens in ECT, it passes small electric currents through the brain to trigger a brief seizure. And it's a very effective tool for managing severe depression. Then, so it's very good and is one of the standard of care for intervention. Then we have here ketamine and S-ketamine. These ketamine is off-label. It is not FDA approved, but it is very effective in treating depression because they're using IV, and you have to go to a ketamine clinic to get this. S-ketamine is better known as Spravato, is FDA approved for this treatment-resistant depression or severe depression. It's a nasal spray and it's rapid acting. And so it helps for patients that have treatment-resistant depression and suicidal thoughts. So again, you got to go to a what they call a Spravato, because the drug's called Spravato, so a Spravato-based clinic that offers these services. So these are three interventions that are available for you to treat your depression. That in when we're getting past to the treatment resistant phase. So this is our, I mean, these are great opportunities for us to move forward, combat stigma, and build hope. So, you know, it takes a village, to help somebody get through what they're going through, to build this hope we're talking about, and to defeat the stigma. So, on the individual level, we could practice self-care. Self-care is whatever you make it out to be, okay? Then we want you to recognize the warning symptoms of warning signs of depression and seeking help. I think that's most important. And help is not a weakness, help is a strength. And that's what I always tell people because I always ask for help if I need something. If I need something with my accountant and taxes, I ask help. If I need help with my car, I go to my mechanic. I'm asking for help. If we are trying to, if I'm trying to fly to Nigeria, I'm not flying myself and my family to Nigeria. We purchase a ticket and the pilot and the airline is helping us get to Nigeria. So I really want you to change the way you think of help and let you go to somebody who God ordained to do that thing for you. Either it's you're going to a chef, you're going to a babysitter, your doctor, your mechanic. These are people that, they are using their skill sets to help you just like you help others with your job. Okay. Then family level. This is it. All of us have to create a safe space for our brothers, sisters, children, parents, nieces to come and talk to us about their depression. If they don't feel like it's safe, they're going to be suffering in silence. Okay. And worse, we don't want them to kill themselves or die by suicide because they didn't feel they could open up and talk. So let's make sure family wise we check in with each other and say, hey, how you doing? I noticed that, for the past few weeks or past few months, you're not doing the same thing. You're not eating your favorite food that we cook for you. You're not watching your Nollywood movies. You're not doing this, but you are just staying in your room all day and it's dark. So what's going on? So we need to have safe space in the family level, community level. We need to host awareness events like we're doing right now, developing culturally sensitive resources and having dialogue in the bigger, grander scheme of society, advocate for mental health parity and promoting representation in healthcare. So this is very possible. You could get help, you could get well, but we need the right treatment and the right provider. And again, like I was saying, for the right provider, it could be Asian, Black, white, Indian, European, Middle Eastern, Arab, whoever, but the provider is culturally sensitive to you. And so that's why it's important to ask around, ask people, who can I go to? Who will understand me and my plight and my cultural background and won't just pencil me in with everybody. So if you could do that, that's very important. And then here's just some basic references for you to look for government resources, medical literature. And this is um, my contact information, my two practices. One is Genesis TMS and Wellness, where I do TMS, and then my psychiatric practice is Genesis Psychiatric Solutions. And here's both our websites. And then on social media, please you can follow me, Dr. Olele on Instagram. And then on LinkedIn, I would love to connect with you. So please connect with me on LinkedIn. And definitely, I look forward to talking to you all on another level in regards to how depression impacts us as a community, especially for Men's Health Month. Thank you all for your time this evening.
Wow. Thank you so much for that detailed conversation on depression. Thank you. I've listened to a lot of talks on depression. This is truly comprehensive and it's in English. Thank you for that again. I respect a lot what you do. Psychiatry was one of the um, specialties that I said I can never do. Oncology was another one that kicked my behind when I was in medical school. But now in primary care, we do a lot of psychiatry. And, I'll talk more about that in a minute. I see that Madam VP, that's our Madam VP, our mother at NAPAC, Nigerian American Public Affairs Committee, has a hand raised. So if you please unmute and ask your question, ma'am.
Thank you, Dr. O, for always fishing out these fantastic professionals. Dr. Olele, great job. Very, very analytical. I have a question and a comment. My question is, this depression, is it trauma induced or is it something that is preventable or avoidable? I don't know. My comment is, when you talk about stigma, a lot of the psychiatrists are, unfortunately, based on the name they name their practices, they further perpetuate this stigma. I'm saying this because there's a place not too far from where I work, and it's a huge building, and it says behavioral health. There's no way I'm taking my son there if I have a son who is going through depression. Because, you know, his classmates or schoolmates will make fun of him. They need to be more discreet. There's got to be better names than, oh, you have a behavior, that's why you went into there. So there are so many ways that we can start working on reframing these services. That could be one of the reasons that you said men are more resistant uh, to this kind of treatment. Thank you.
Yeah, no, that I value your statement, and because everybody is situation is different and different things, and I value that because one of the things I will address. Wait, first you mentioned about the names because that's the one that I remember that last statement, but then I'll also um go back to the other things you may ask. If there's something I forgot to answer you, please remind me, please. With the name, that is a big issue, and a lot of psychiatrists, I know for us, when my wife and I were creating our practice, we battled with that, with the different names, and this is pre-pandemic. Now it's better because of the pandemic has allowed many people to get services, but after COVID, but the stigma can be in the name where you say psychiatric service, behavioral health, but it could be good and a bad thing where somebody's walking into the place and then they're thinking, oh my God, people are seeing me walk into this behavioral health center. Or it could be a blessing where they could find it. But a lot of times, the reason why providers put these names like psychiatry service, behavioral health, so it could be on Google it or Yelp, they're easily searchable and they could be found. And so that's one of the reasons. And so a lot of times, like my practice is hybrid. We're in person and virtual. So maybe a way to break the stigma is to go through virtual appointments. So that way you could find that it's easier for you to just get psychiatric care in the comfort of your home on your laptop or your phone. So that is one way to address the stigma is the access. And then definitely, and I'll tell you, and I would tell like your son if he was ever coming to this, I'll tell him, you don't know a lot of your friends that you're trying to be impressing, them and their dads and their parents are coming to these services too. So that's the thing. I always tell my patients that I'm like, I see CEOs that all the way from CEOs to homeless person. So everybody has problems. The rich man has problems, the middle class man has problems, the poor man has problems.
On point. That is true. But is depression traumatic?
Oh
Is
yeah,
it
thank you. Yeah.
trauma?
So The question of that is it can be from trauma, but depression could come from different things. Depression can come from family genetics. So that's why it's very important to understand your family medical history, your family mental health history, because who knows, your grandparents may have had depression, but you didn't know they didn't know what it was caused. They didn't have a name for it. And so that person in the village or wherever you grew up back home may have been, they were like, yeah, he was always to himself, or he was always in his room, or he slept a lot, or grandma slept a lot. So that's depression. Or they have a cousin or an auntie or somebody that would feel hopeless or worthless. They gaining weight, and so that might be depression. So why it's very important that I ask, do you know anybody in your family that has depression? Because, and that's why this is very important that we talk about it at a family level, because if you're not aware, then you won't know, and you're like, where is this coming from? You might say which spiritual attack I'm having, but you didn't know that your brother, your sister, your mom and dad did have depression. So that's the genetic piece of it. Then there's environmental factors. So we have genetics, environment. When I say environment, meaning like, are you stressed at your work? Are you stressed at home? Your community that you live in, is it safe? So that's causing you to be depressed. Are you unemployed? Is that causing, so your financial stressors, your environmental stressors could cause it. Trauma could also cause depression because you experience something and you may have PTSD, but then also you may have depression. So there's a lot of factors that may impact depression.
There's also serotonin imbalance in the brain.
Yes, chemical imbalance, definitely.
Imbalance in the brain. So it's not necessarily your fault. Actually, most of the time it is not your fault. But getting help is very important. Not getting it then becomes somebody's fault. I must say before I call on this next person that raised their hand that we don't establish physician-patient interaction on this platform. We give you correct, excellent information. And please, if you have any of the symptoms that Dr. Olele discussed tonight, contact him. That you see his website on here, social media handle. Contact him and get help. If you don't, you will never function at your highest and best capacity in life. You will just go through life, in a haze. And none of us should be like that. Let's dis let's take away the stigma from this very important mental health condition.
Yeah, Dr. O. And it's not just the mental health. Men don't go for medical, they don't go for dental, they don't go for any checkup. So it's
That's it. That needs to change, please. That's why we're having this conversation. Thank you so much for bringing that up. It's why you men are very important to us. Did you see it's us women that are talking and talking and talking? Because you are important to us. You are the heads of our households. Please seek help, both physical and mental. The assistances are there, the resources are there. Contact me if you don't know how to go about it, and I would help you navigate. It's a promise. Tibena, kindly unmute. Tibena is one of our medical students.
Hello, good evening.
Good evening.
It was a lovely presentation, Doctor. Thank you so much for taking the time to speak with us. One of the reasons I raised my hands is because I deal a lot with young persons, kids and babies, even, well, not so much the baby, but just kids and teenagers who express the desire to want to be in therapy or to speak with a therapist or to go to any psychiatric help. But we get a lot of pushback with parents thinking that it's a direct relation to their parenting. So I just wanted to ask about your guidance on how does one initiate that conversation, parent to child, that that separates the depression from them directly taking it as offense to their parenting.
Yeah, so this is where I think it's good for the the place that's providing the service to have something in their protocols of how to address or bring this to the attention of a parent. Like you could have a behavioral report card or a sheet saying, "Oh, we noticed that Tommy was sad. He was more angry with his friends. He was alone a lot. So these are something we're concerned." Maybe bring this up to his pediatrician. Maybe bring this up to like say go see his pediatrician or bring it to what's going on, and then you could leave it where you can make it open-ended. We're here to support you and provide resources. And then that way you could at least start the open dialogue. And if the parents want
Oh,
to
then that's not your ice cream.
if the parents want to divulge more information, they can. And but if not, if they're gonna feel offended, just make sure you always say this is coming from a place of love or anything because we care about him. But we've seen this is not a reflection on you, but this is what we're seeing with him in the classroom. And a lot of times, when you say maybe follow up with their pediatrician, that might be the best thing to go and they see the pediatrician, and the pediatrician may give them referral to a mental health provider.
Okay, thank you. And I also wanted to ask, as it relates to persons who have high functioning depression, if that's still the term that's used. But a lot of persons deny wanting to reach out for help because they think I'm still doing my job well, I'm still performing well at work. So then how then those to have those conversations be started because there are aspects of their lives that they're neglecting, but they think that since they're still performing in society that they're fine.
Yes, this is very important. I'm glad you brought this topic of high functioning depression because since we're talking about Men's Health Month, there's a lot of strong, powerful men who, despite that, they have a lot of people relying on them. And so they're functioning because even though they're depressed, it's taking a lot of energy for them to get things done. Like, because
Hello.
the bills need to be paid, they have to lead their businesses, their teams, or it'll fall apart. And so they're carrying on this financial burden, community burden, um, and personal burden, and then they neglect themselves because for the sake of being strong all the time. But that could kill you because when you're starting neglecting yourself and you're depressed, you're not taking your care of yourself, you're not exercising, you may get high blood pressure, you may get stroke, you may not go to your doctor's appointments to get screened because these are all things that occur with depression when you start not you have impairments. And so somebody with high functioning depression is definitely neglecting themselves. And then it might lead to self-medication like substance use or even things that might impact the family where they're not engaging as much with their spouse, intimacy is low, they're not active with their kids. So there's a lot of things that a high functioning, strong man can be dealing with.
Yeah, thank you so much. And thank you for that question. Very important. I think there's one that follows that also in the chat box. We'll get to it in a minute. Mr. Hodge, kindly unmute and ask your question.
Yes, Dr. O, thank you for recognizing my raised hand. It's a follow-up. I think you had answered partially my question, and that is I want to resonate Dr. Okay's question on the chat box about providing a list of available culturally sensitive support groups. And my question directly to Dr. Ifeanyi, thank you so much for an excellent presentation. Do you provide, I know you did say, you do a hybrid, so virtual as well as in person, but in these hybrid sessions, are you open to counseling, or would you recommend again culturally and socially sensitive counseling sessions? For your patients. That's the first question. Again, that is in to resonate Dr. Enye's question. And finally, Dr. O, uh, do we have access to these questions and responses in the chat box, as well as the recording by the earlier participant that volunteered to record the session?
This session is streamed live right now on YouTube. So you have 100% of what is happening here on YouTube. Also on Facebook. So you can search for Medical Mondays with Dr. O on YouTube, and you will see this session as well as all the other sessions from the past. So it's on there.
Thank you.
Live. You're welcome.
And in regards
So
to
the questions, Dr. Lele.
yeah, in regards to the culturally sensitive support groups, there, I would say the best thing to do is would be to go first look for an organization. I mean, you could that has the type of doctors you're looking for. So, for example, I'm a member of the Black Psychiatrists of America, and so they have like a directory where you could be able to or go to the website and make requests to see like a Black doctor or somebody that is culturally competent there. And so that way they could have resources because every city, state, or has different types of resources. I'm talking basically in the United States. So that's one. Then also two, there is a Nigerian American Psychiatric Association. There's there's different there's different African groups that have their own medical society. So that's probably one of the best places to start and see if they have any support groups or they know of because everybody's network, they may know somebody who knows somebody that has the what you're looking for. So that's one. But one thing I always say is start with like look at NAMI.org, NAMI.org. That's a good place to start with to see, and you could ask the questions, is there anyone that has culturally sensitive care? But when you're looking for it, just type in either Black such and such support groups or whatever African based, whatever you be as specific as you can in your searching. And and then definitely, if there's anything, if you're looking for something, maybe you can message me and I could ask my network and get questions. And all it is connecting with somebody who may be doing what they're doing, what you're looking for. And in my sessions, I do my practice, I do med management and TMS. Then there's a smaller portion of patients I do therapy with. And and when I talk with them, I always say, um, I'm always not assuming that I know everybody's life because let's say because we're both either African or Nigerian, but I come from a place where at least I know the immigrant experience, either first gen or somebody coming in and we'll build from there because I never want to do is assume somebody's life is the same as mine or different. And I'm just meeting you when you come in and we go from there.
Thank you very much for that answer, Dr. Ifeanyi, and thank you. I think your contact information has been just posted, so that is great. Thank you.
Thank you.
Thank you. Dr. Aluya, our
Yes.
president at NAPAC.
Hello, good evening, everybody.
Welcome.
Yeah, thank you, and thank you, Dr. Ifeanyi Olele. Great work. I wanted to ask because in physical medicine, we always know the etiology of diseases and apply therapy based, essentially on them, but the usually varying or in combination of it. Now, in psychiatry, with the etiology you talked about, you know, genetics and environmental. Now, the treatment modalities that you talked about, is there a graded level of approach or is there some protocol we compared to one etiology or another, or you could just combine or as a pick and choose depending on who the physician is?
Great question. So it's definitely on the providers, the way they do their own algorithm. But so like, let's say for me, I'll use myself as an example. So somebody comes to me and they're saying they're depressed. So I do rating scales, and so I could see what's the level of the severity of the depression, if it's mild, moderate, or severe. If it's mild, I will tell them you don't need medication. You may need to get out your situation. If there's something with your job, let's find let's see, let's figure out. Or if it's more, you could get coaching if it's about work, if it's about your relationship that's causing you to have the depression, maybe go to couples therapy or individual therapy. So I go to the level of severity. If it's now at, let's say, moderate to severe, then I'm saying let's introduce medication, then also combine that with possible therapy. So we could go either way. If it's now in the severe, definitely medication therapy is needed. But if they've tried multiple meds and every time they try a medication, the next medication, they keep not getting the therapeutic results, that's when I would say, let's go to a psychiatric intervention such as TMS, ECT, ketamine, or S-ketamine nasal spray.
Great, thank you.
No problem, doctor.
Okay, thank you so much. Dr. Izugu, kindly unmute. That's a cardiologist, top cardiologist in town. Kindly unmute and ask your question. There you go.
So sorry. I'm having issue opening up the app, but it's all good. Dr. Lele, thanks a lot for that presentation. Excellently done. I have a couple of questions, more to do, again, Nigerian men, first generation, those in Nigeria. And if you can give us some comment on depression among Nigerians, men in Nigeria, if you have that information. Because many times people talk about, oh, Nigerian problem is more physical, not mental. So I need to hear, any comment. And then also the first generation, Nigerian, men, and depression here in terms of the challenges. And last but not the least, postpartum depression in men.
Okay.
Thank you.
Good.
Wow.
So, for the numbers of like depression in Nigeria, I don't really have those numbers because I don't practice it in Nigeria. However,
Okay.
I do know that there is levels of depression because sometimes I do get people that contact me internationally that I know and they're telling me their situation. I'm like, oh man, you're dealing with depression, and the depression could be based off of genetics, which they don't know. So we kind of talk about, when I'm just talking to them, I was like, do you know if your your dad or mom or somebody in your family had this? And they're like, yeah, my dad was always problematic. He would always have this issue. I'm like, oh man, this could be depression. And then another thing is access to medicine. So sometimes they have to see their family medicine physician to get the access to medication or generic medication. So um, there is help out there, but it's not as detailed here in the United States.
This is,
Very, very open. And then you mentioned about the postpartum piece. Uh,
yes.
that is very prominent, that there are men that can struggle with that depression because yes, definitely focus on the mother because she delivered, but also men could struggle too because they're also even though they're not taking the physical toll like the mother with the breastfeeding and being with the baby, but the man could also go into depression because they may have the new pressure of, oh, I have a new child. I have to take care of my wife, my kid, or my children, even if they have other children. And then the sleepless nights may impact somebody that has a struggle with depression and sleep. And so lack of sleep could trigger them to depression. And also, if they have unresolved issues of being a father or they didn't have a father in their life. And so we don't know how everybody deals with new changes in their life. So that's where a postpartum depression could look like in a man. And then I believe you were asking about first generation Nigerians
German.
here in America. And so, like, here's the thing with first generation Nigerians in America, or even abroad, first generation UK, first generation in whatever, Dubai, wherever you're at, you're dealing with um a cultural two cultural identities. Here in America, you are Black, African American. In your household, in your community, you're a Nigerian. So sometimes you're dealing with that double duality. And then your parents didn't grow up here. So there's sometimes a cultural not understanding of the way that your parents grew up in Nigeria versus the way you grew up here in the States, or you are growing up. So the person can feel isolated or alone at times and get depressed based off their household situation because they could feel, oh, my parents don't get it. They don't understand. And their parents at the same time are struggling. I have to give parents their concerns too, because they're struggling because they're raising kids in a land that is not familiar to them. So that's where there's a conflict. I'm a first generation Nigerian in America. So my kids are second generation Nigerian. So they have a mixture of, the added layer now, my parents and me, we have that advice we could provide them about being Nigerian in America because we've went through a full generation of living here and we're able to provide support. So now we're getting a lot of second generation Nigerians here now. And so that's why it's important for us to support them, the kids coming up, but also do the healing that's necessary for first generation Nigerian Americans to get the therapy about unresolved trauma, unresolved issues, because a lot of, I don't want to make a blanket statement, but a lot of first generation kids dealt with being made fun of because of their name or being made fun of because their houses had a certain smell because of the food. And so, or try to invite your friends over and you're trying to, oh, let's eat pizza, but why can't your friends eat fufu and ogbono soup or egusi or whatever the home, because why can't they? But they're embarrassed because of the way the food looked like. So these are a lot of stories that everybody has different stories, and you don't know how it impacts a person growing up. But there's also first generations who when growing up are very proud of, I'm Nigerian to the core. I'm so happy. So everybody's story is different, but we need to hear everybody's story. And that's what a support group will be, and people sharing. And when they share it, the more that is being shared, it could help somebody get out of depression, because a lot of times that individual who's first generation, we don't know how their brain and their environment impacted them. And so that might cause them to make certain decisions in their life with, work, finances, occupation, because of even pressures from the family, like, oh, you must be an engineer, you must be a doctor, you must be a lawyer, or you must marry Nigerian, or you must do this. So there's a lot of pressure that they get because of pressure from the family. So there's a lot of dynamics. That's why I always say I would love for African families to go into family therapy, but it has to be with a culturally competent is to deal with the parents as well and the children.
Thank you so much. Excellent.
Thank you.
Thanks.
So, Dr. Olele, kindly pull the slide down. And to everyone, I have Dr. Olele's contacts in the chat box, and I'm going to be posting and reposting because we see that that is really effective when we do that. Because then you can click on it right away and go to the website. I tried on the screen and could not do it. So I copied them in the chat box so that you can click on it and go there and save it on your phone or your computer. Dr. Bokwola, kindly unmute. Thank
Yeah,
you.
thank you very much, Dr. O. Dr. Olele, you covered a good ground for us. Thank you so very much. But the response to the cues, the questions actually panned it all out. But let me quickly point out an area. I deal with people with disabilities, and that spans a lot of depressive syndromes. So when I'm looking at your at the presentation and listening to you, and I see the various treatment that are available. Luckily, I think one of the doctors, I don't want to mention his name, did ask about the algorithms. I have a patient who had seizures disorder, 9 to 10 seizures a day, and it's in college.
Wow.
So, and of course, it's sometimes we were able to bring it down to 2, but after a while, it's going to spark up again. But it's mental state, and it's always in state of depression. Okay, so I'm wondering, do you have to start with what do you call it, behavioral therapy, psychotherapy, and all that? It won't work.
Yeah, so
Okay,
that
and the other two ones is cerebral palsy and mental retardation that became adult cerebral palsy. Okay, their mentality is not going to capture most things. Are these guys go straight to the other alternative therapies? They haven't been offered, and they've been going for sessions in behavior modification and all the other things. So these are some of the ones, and luckily somebody has asked about postpartum depression. I didn't know men had postpartum depression. Well, let me also now make a contribution to the area of, I don't want to use this opportunity. Thank God that you have that Nigerian American Psychiatric Association. I think one big thing that we really need is that there's nobody that came here who didn't get some challenges that touched on behavioral changes. And I know a kid who is now so much an adult who became a vegetarian just simply because his classmates were mocking him that he was always smelling like fish. And he stopped eating beef, he stopped eating fish, and became a vegetarian. And of course, all these have consequences we must be doing we may need to do something about encouraging newcomers about some of the things they are going to face with their children. Thank you.
And
oh,
thank you. Before you answer, Dr. Lele, I just want to point everyone to the chat box to see that Dr. Ifeanyi last week talked about postpartum depression, that he actually had it. And now he has posted a link uh, for us to see where he talked about his personal experience with postpartum depression. So it's in the chat box. You just have to click on it again and you'll be able to get to that link. Dr. Lele, back to you.
yeah, so this is where we talk about comorbidities, knowing your patient, because if I was getting a patient with a lot of seizures or cerebral palsy, I would definitely want to connect with their or collaborate with their neurologist, their family medicine doctor, whoever is their treatment team, because there might be medications that I propose that may trigger the seizures or make the condition worse. So that's where I would lean on their guidance because they're the masters of that treatment of the seizure. So I would lean on their guidance and say, okay, what medications do you want me not to supply? Or like somebody having a lot of seizures, they would not be a candidate for TMS that I provide. So that's when we have to look at all options for each patient, customize their treatment, and see what will be the best treatment that won't cause harm for them.
Thank you. Auntie Tower, kindly unmute, ma'am.
Good evening, everyone. And Dr. Olele, thank you very much for the wonderful presentation. You already answered some of my questions in your last answer. My question was, one of them was, can electroconvulsive therapy make someone that is on the brink of having convulsion go to a full-blown seizure? and you just answered it. So the other one is, do you deal with the pediatrics and adults as well?
Yes, so I do see children usually or people 13 and up, but I do see some people under age 13 based off if it was a referral from my colleagues in the community who are therapists or pediatricians or family doctors or hey doc, this is my patient and I want to because I know the doctor, so sometimes I do take younger patients than my 13 and upper range. Then I do TMS to patients age 15 and up as well. So yeah, I do it. I look at the adolescents because I'm not a child and adolescent psychiatrist, but being a general psychiatrist, I could still see them.
Thank you very much.
Mhm.
Thank you. Thank you so much. Adanze Agua, kindly unmute and ask your question. Thank you.
Okay. Hello, good evening,
Good evening.
Dr. O. I called in late, but I missed the doctor that was speaking. I'm very glad to be here. At least I had a little bit of your discussion. I am a psych resident. Will be completing my residency soon, adult psych at UT North. But I have a question regarding some of the resources that you listed, the Nigerian Psychiatry Association. And I think you mentioned 2 or 3 of them. I didn't get all of them. I would like to get the information,
Yeah,
if you don't mind.
I
And
mean,
also, I would want to know if you've not heard of AMPER, Association of Nigerian Physicians in the Americas,
mhm.
if you belong to any of the chapters, because we do also have the mental health membership there.
Well, I belong to AMPA, and
Okay.
he will belong to my DMV. If he belongs, he doesn't belong. Dr. Lele, I'll talk to you about AMPA. There is the Association of
Umbrella.
Nigerian Physicians in the Americas. I will share with you of this program.
Yes, I think being a second generation American and also being in the mental health, which is an area that we have a lot of stigmas, especially back home, he will be a very good resource
Yeah.
to AMPER if he joins AMPER.
Yeah, and there are some other psychiatrists also on AMPA that would be nice for you to connect with. I'll talk to him about that off this program. So, Dr. Lele, if
Thank
you'd
you.
like to share those associations she
Yeah,
asked.
I'm Googling a
Thank
lot of
you.
them right now because I know there's also in this area an association of Nigerian psychiatric nurse practitioners as well. So
Really?
yeah,
Oh, I didn't know that one.
Nigerian Association
Thank you.
of nurse practitioners. I'll put it. I'm trying to remember the exact title, but I'll give you the link.
Thank you. Dr. Kwokwola, you have your hand raised again? Or
Oh, maybe it just got stuck there.
okay, sorry.
Let me quickly just ask why I was asking those questions because these are all the people, the several persons I'm referring to. Definitely, we know that in state of is there a condition called acute and chronic depression because they have exacerbations up and down.
Okay, Dr.
Specifically,
Kwokwola, with
yeah.
any disease entity, depression is possible. Even with people who have had heart attack, we see high rates of depression in them. Like Dr. Olele said, it has to be a collaborative effort to take care of these patients. The primary care doctor, the neurologist, if it's cardiologist with heart attack, and the psychiatrist, even and the counselors. It's a teamwork. We all work together in those instances to assist this patient. Somebody having seizures 9 to 10 times a day, the seizures need to be controlled. I don't care what kind of antidepressant you put them on. If they continue to have seizures that many times a day, they're going to be depressed. So it's a collaborative effort to take care of such patients. Well, it's a very important it's a very important question that you brought on because it's a real thing. It's going on in our midst. And but we see some of them and we all work together to take care of them. Thank you.
All right, thank you.
Thank you. So Dr. Olele, I have some questions in the chat box. Our amazing, Temi, who has brought African culture alive in the fashion world. We just attended his program this last Friday, said that he wants to, oh, this is the thank you. I'll come back to that. Sorry. He did ask another question. He was thanking the Medical Mondays family for coming to his program. But he had another question that I saw earlier. He said, can someone be depressed and still appear happy or productive? That's
Yeah.
one question. Another question, how is depression different from simply feeling sad or down?
Okay, I'll first start with the feeling sad or down. I was actually talking to somebody about that today, actually. So if it's clinical depression, if it's more than 2 weeks that you're having the symptoms, and it's those symptoms are showing up consistently, and you have 5 out of 9 symptoms, that is for 2 weeks consistently, and then you either have depression and or the loss of interest, what we call anhedonia. Then feeling sad or blue or down, that could be a couple days, but it doesn't go past that, where for a day, like let's say, for example, with something as simple as, let's say, the Nigerian soccer team lost a game and then makes you feel very sad. It bothered you, affected you. You're sad for a day or two, but that's not depression, that's sad. Or you lose a job and you may be sad for a short period of time, or you break up, but then when it gets to the point where it is impacting your functioning, then we'll say, yeah, we're looking at depression. But if it's more like I'm sad about it, but I'm still able to function, then we won't really classify it depression. But everybody's different. I would do a screener to see where you fall into that. And then there was another question, I think, about.
Yeah, it says, can someone be depressed and still
Oh,
appear happy or productive?
yeah, that's what we were saying, high functioning depression, where they're very productive but there's a term we call masking, when a person puts on a like that fake the smile, they're masking what's going on because they don't want nobody to know what's going on. So outside, they're smiling, they're at work, they're doing their things, but when they come behind closed doors, they're crying, they're depressed, and they're not functional. But when they put their job, go to drive to work and step foot on the job or school, they're smiling. They want everybody to, so nobody bothers them or asks them, oh, what's going on?
Thank you so much. That is important, very important. When you feeling the blues and it's over 2 weeks, please get help because that's not something that is passing anymore. Is there any medical link between depression? Just 1 second, please. Let me try mute this person. I can't find them. Thank you. So the question is from Dr. Alu. It says, is there any medical link between depression and excessive use of the social media?
So I mean, there's not, I mean, there's a lot of studies on that right now, and we're still in the infancy stages of it, but I don't want to make a blanket statement, but I can see where if somebody based off self-esteem, but based on their self-esteem, the way they view themselves, if they're comparing themselves to others, like they're saying, oh, like for example, oh, Dr. O's Medical Mondays are fantastic, and my financial Fridays is weak, or they're comparing that, or they're saying, oh, this family is always going on vacations and we're not. And then when you start comparing yourself to somebody else, then you could start getting depressed, because remember, depression is a personal thing where I don't know how this person's brain or their behavior handles seeing other people's success and they're not there. There are some people who are congratulators where they see their friends or family, they're going on vacation, or they're buying a new car, or they got a job promotion. I don't know what their maturity level is or their self-esteem level is, where they could be happy for somebody, or they could say, oh man, that person, I know that person went through a lot to get that nurse degree, or to get that law degree, or to get their PhD, because they've been through a lot. So I am genuinely happy for that person, because I don't know, versus somebody may look at it as oh, look, he got his PhD, oh, he got his doctorate, or he bought his mom a new car. Look at me, I'm a loser. I can't even do that. So everybody has their journey, and we're also just looking at a snapshot in social media of that one page. Nobody knows that if you took that picture, you had an argument with your wife or children before you took that picture. Nobody knows if you had a flat tire before you got to the airport, or you got pulled over by TSA or whatever before you got on the flight to take that picture in Hawaii. So we're always looking at that 1 second picture of bliss of somebody having a good time, but we don't think about what happened before or what happened after. So everybody's just taking a picture just to show. That's all.
Great point. So, another question says, you mentioned that low libido and insomnia could be side effects of depression medications. No. So, how do you manage those side effects so as not to worsen the depression you are treating?
Thank you for asking that question, because again, we're all adults in this room, and I always tell patients, so because I'm used to talking about sex with patients, so this is normal for me. But I know some people it may be uncomfortable, but I just always, to break the ice, I always try to joke around and say, well, you came, unless you're immaculate conception, your parents did something for you to get here, and then you did something to have your kids. So I always try to break the ice, so to make, sex is normal in a relationship. But in regards to like the libido issue, um, I always tell my patients, and I always tell them, I do not want to wreck your sex life with you and your spouse or your partner. I do not want to do that. So the moment that you notice that, and I'm gonna say I know we're talking about men's mental health month, but I'll also say for our women too, um, if you notice that you have less sexual desire, less arousal, or a man is not able to ejaculate, or it's delayed, or a female is unable to have an orgasm, um, or has, so those, or a man is not able to get up. I say that, and the cause is either from depression, or if when you're depressed, that didn't happen, but when you started the medication, it happened. Let your doctor know immediately, because I would rather you tell me than you stop taking the medication. Let me know, and I could say we could either lower the dose or switch you to something else. And it's important because um, scientifically, we have receptors like serotonin receptors all over our body, and we also have it in our genitalia too. So that's when you take the medication, that could be a side effect. And then in regards to the insomnia, so I always tell patients that the medication can make you have insomnia or you sleep too much. So again, tell the doctor about that, and he may give you advice like, for example, but still talk to your doctor about this. If you take the medication and you're sleepy during the day, the next 24-hour cycle, you probably take it at bedtime. So you could sleep with the sedation. But if you notice, if you're taking it at nighttime and it makes you can't sleep, the next 24-hour cycle, you take it in the morning. So that way, it will keep you up during the daytime. So those are some common side effects, insomnia and libido issues.
Yeah. Thank you. So, I've been using this testing, gene side testing, to assist in, knowing what will be the best medication to pick for a patient when it comes to mental health treatment. It uses the patient's DNA to figure out what medication will work for that patient, not for their siblings, not for their parents or anything like that. And it's been very helpful to be able to, like tailor things down and not be groping in the dark. When patients, they've told me that before, what you said, that I don't want to be used as guinea pig. Is why I don't want to take, yeah, I don't want to treat the symptoms. And they know they have problems. They want to get better. So the gene side testing, when I explain it to patients, have been very helpful because then they agree to do it so that their medication can be tailored to them, and they do well.
Yeah,
So
I use
that's for
Genomind
that.
as
Yes.
well. Yeah, yeah, GeneSight's good. I use Genomind, and there's another one called Tempest.
Tempest, that one does a lot of other medications. Is that one?
I think so, but yeah, but I use Genomind, and then I use GeneSight for some of my patients as well. So yeah.
Fantastic. So you mentioned something before about, what to do in bed to aid sleep, sleep hygiene. And I just want to, maybe add a little bit to that, that it's very important that we turn off the lights, turn off the TV. Some people leave the TV on and expect to sleep. Your brain keeps working and, can prevent sleep. You said, what to do in bed is sex and sleep. I would like to add prayer. I say three things,
Yeah, three,
in
yes, yeah,
bed.
yeah, yes, 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 yeah, exactly.
Three things is sex, sleep, prayer. But we should not be reading in bed or bring work to bed and be doing that because it would affect sleep. That is very important. And what else is that right here? I'm always taking notes. Thank you for that culturally sensitive care. Our Caucasian counterparts are fantastic, well educated, well trained, and they do amazing. Um, our brothers also that are, Africans, African Americans, are excellently trained, educated. We all know our stuff. However, when it comes to culture, culture is culture. We can identify with each other better than, within a culture, you can identify better, with somebody your culture. So when it comes to mental health, I've seen that uh, counselors who are the same culture are very, very helpful for the patients. So please, I say it all the time on this forum that everybody needs a counselor. Look for somebody that you gel with, you can talk to, who understands you. It's very helpful in mental health, mental health wellness. So that being said, I want to, before I come back to you again, Dr. Olele, to give us your closing remarks and encouragement. Temi said to the Medical Mondays family that he wants to sincerely thank us, every esteemed member of the Noble Medical Mondays with Dr. O community, for attending the DMV African Cultural Fashion Heritage and Award Night on Friday, 4.0. He said, your support and presence meant the world to them. From the bottom of their hearts, they are very grateful. And I want to say thank you, Medical Mondays family. And for those who volunteer, I actually saw one of our people volunteer and was there from 1 o'clock till 2 a.m. Was there when we were leaving. So thank you very much, Medical Mondays family, for always being there and for always supporting. Dr. Veronica said, thank you, Dr. Olele, all in caps. She really appreciates your conversation with us tonight. And Mr. Mashid said, amazing presentation. Thank you, Dr. O and Dr. Olele. Thank you, Dr. Olele. There are lots of thank yous here. I don't like to miss them. People are appreciating you for your imparting into us tonight. And Dr. Alu asked this question. He said, what is the place of religion in resolving depression?
I am so for it, and I'm about spiritual wellness. But here's the thing as a provider, and I know Dr. O probably agree with when patients come to me, I am a Christian person, I'm a believer, but I cannot put myself to them for so my one thing is I allow them first to say something to me like oh about God in my life or anything then I say do you mind if we talk about this in the session so because faith is a part of your life. So just as you have financial stress or financial joys, occupational stress, you could also have spiritual stress, spiritual joys, and so it's a part of your life. So a spiritual like anybody can have struggles in their religion, such as oh my church, I don't think my church is the right place for me, or I'm not connecting with my pastor's message, so it's making me depressed, or I love my church community. They fuel me or whatnot. And so I'm always encourage them to, if that's part of your life, nurture it. So if prayer, get your prayer points well. And I always say this when you're praying, you know, God, I truly believe this. God puts us each on this earth to be a angel to others. So, or helper to others. So, put in your prayer points, God, please send me to the right psychiatrist or therapist that will heal me, or send me to the right family medicine doctor that will heal me, or pray for your doctor that you're treating that's treating you, just like you pray for the president or whoever your president of the United governor, or you pray for your the pilot flying having the God's hand on the airplane. Do the same thing. Pray for your doctor to have God's hand on the clinic, hands on the doctor, so the doctor could put his wisdom onto you from God, healing, I mean, guiding him, his steps with you. So that's important. So put that as your prayer point, because it's very possible because God is very powerful and God will put somebody in your path to help you.
Fantastic. Thank you so, so much. My 100% believe. Mrs. Nike Fality, kindly unmute, and then Dr. Jagbe.
Good evening, everybody.
Good evening. Welcome.
Thank you, Dr. Lele. Thank you so much. You have shared a lot of very, very interesting points on this topic. I wish I knew you like 12, 13 years ago because I have suffered depression in the past. Glory be to God, I'm 100% now. I suffered depression for 10 years. Dr. O knows, she knows me very, very well. A lot of people do not, especially the Nigerian community, don't really, really buy into depression. They just they stigmatize, like you mentioned. They think it's out of place or probably it's a spiritual problem and stuff like that. Mine was triggered by a huge financial loss because we used to live in America then for like 20 years. Then we got an opportunity to go back to Nigeria because my husband's a banker. And Nigeria happened. We only stayed there for 3 years. We had to come back. He was still struggling to, still be part of that community back in Nigeria. I came back with the 3 children all by myself. Children are grown, a lot of activities, extracurricular activities. I had to do so many things by myself, and then depression happened. It was a very, very, very challenging time, but all through it, I give glory to God because a lot of good things came out of it as well. Because when you go through a situation, you learn more. Um, People just see you as like, oh, what's wrong with you? This is somebody that used to be very active. I used to party. I loved life. I was a serial businesswoman and all kinds of. I just lost interest in so many things because I was really truly troubled about the future of my children. And chemical therapy didn't work for me because, like you said, a lot of the doctors do not take their time to know who their patients are. What would work for A does not work for B. Definitely, chemicals didn't work for me because you do not take time to know what the constituent of this person's genetics is. Like, probably if they had tried the genetic way, it might have worked. But I, coming from a biochemistry background, knew very well. I mean, when you put a chemical in your body and it goes the other way, you know definitely that's not for you. Because it was just not working. So I stopped. I did not. I spoke to my doctor. I said, no, that's not what would work for me. And somehow along the line, the psychotherapy uh, treatment was what worked for me, and also um, reversal of the situation healed me perfectly. So I mean, it was like from a 0 to a 360. My husband and children could not believe it, the way everything just reversed. Because it depends on the root cause of your depression. People, you cannot generalize, as you mentioned, as a doctor. A lot of our doctors would just assume, oh, this person is good, put them on so. It does not work like that. I'm so happy for this forum because this will create more awareness, and you, as God will have it, to the glory of God, I've been able to impact so many lives. I have a particular case in hand right now. I mean, I'm not a doctor or anything, but I'm just coming from being in that situation before. I have a high school friend right now that I'm working on, and I wanted to ask if you have any UK support group, because she is such a difficult one to work with, but with prayers and with a teamwork, I believe she would be pulled out. I've worked on another friend in Canada who I thank God she's come out of it as well. So I would really, really, get with Dr. O, because being that I'm coming from that space, I've been in that space in the past. I would not like to see anyone around me go through that. So if there's any UK support group for this particular high school friend of mine that I can, you know, we can, help, I would really be grateful. Thank you so much.
Thank you. Thank you for sharing. Thank you. Dr. Olele, you know any UK group?
I don't know any UK groups,
Don't
but
worry, Nick. I'll revert back. I'll find out and I'll revert back. Her situation was situational. We do have something called situational depression, and you're right. When the situation is reversed, the symptoms would dissipate. Thank you. Thank you for sharing. Dr. Ajagbe, kindly unmute. Oh, by the
Yes.
way, Dr. Ajagbe graduated from the University of Ibadan 45 years ago today. So he's wearing the T-shirt with the 45th year anniversary stamped on it. Methuselah. Go ahead, sir.
Thank you, Dr. O. Yes, 45 years ago, exactly today, 23rd of June, we had the ceremony of, graduation from the College of Medicine, University of Ibadan. So I'm very glad to still be alive and reaching out to my, classmates. We're trying to, kind of just hang out and, reminisce all over, the 45 years experience. Anyway, thank you for sharing that, Dr. O. Dr. Olele, right? Okay. So thank you so much. Everything you shared, resonates with the kind of people that I interact with, albeit they are dental patients. But a lot of the things that you talked about, manifest in so many ways in some of these patients. Now, one thing I didn't hear, maybe I, kind of just missed it, is the word resilience during your presentation. How resilient could you rate the people, Africans that, grew up in the kind of era that I grew up in? And I think many people on the platform also grew up from that. So many children in those days were told to be seen and not be heard. That's number one. So adults are talking, shut up. Don't even, no opinion from you. In many families that I'm aware of, regardless of their socioeconomic status, in so many of them, children who are either because of delayed development in terms of musculoskeletal skills.
Oh yeah, yeah. He's in that room.
They were
Which
they
one?
were
Which
labeled
room?
as
Up on
being
the higher. That's
clumsy.
up where I'm at. Oh, he's on
Because they
this
were
floor. On this floor.
clumsy,
Okay.
many times they were told they will not amount to anything. They were constantly barraged by their own relatives, by their own family, that they will not amount to much. That even kind of, when children even got to high school in the dormitory, like in boarding schools, they were subjected to all kinds of stuff. Despite all of that, many of us that experienced it, we still were resilient enough to not go into depression. Now, I don't know how we can categorize that. Was that genetics? Was that environmental? Was that because the factors to draw people into depression were there? Yet, people bounced out of that despite what they went through in high school, despite what they went through in their own home. They still were able to do very well. I don't know too many of the people that I know experienced some traumatic childhood experiences that didn't make it. I don't know any of them because they were driven by the fact that they will amount to something. And that determination brought about something which may not easily be put into words, the determination to succeed. And you see many of them, they are very driven. So anyway, I just wanted to put that out there that there might be something that could be learned from that kind of segment of the past. For people who might be experiencing the challenges here, how can there be some kind of resilience? Not that they would deny the existence of problem. That's not the point. If they have problem is diagnosed, where is the role of resilience? Thank you.
Yeah, resilience is I like the word resilience a lot because resilience means that you could get knocked down, but you're able to get back up.
Absolutely.
And the thing with resilience is, I think I feel it is taught or nurtured, and it depends on like, so the people that you may have been talking about, they were probably unofficially in a support group where people would motivate each other, encourage each other, and that there was ability to be resilient. But there's times though with the people that you may have mentioned or people who have similar circumstances, they may show up because may have high functioning depression where they're able to function, do their task, smile in public, but privately they were struggling. But their resilience got them to push through and provide for their family, make something of themselves, but they could still be depressed. You could still be depressed and resilient, but resilience is something that will help carry you to push you through to fight the depression, to fight your current circumstance. So everybody is built differently. And so some people do have the ability to, based off their environment, to push through or their genetics, but others, because of their way they're nurtured or hardwired, they may not be able to take the challenges.
Thank you.
Thank you. Dr. Buka.
Yes. Hello. Thank you. This was very interesting, but I just have a comment. My daughter just called me. I said, I'm listening to this thing. And we're talking about immigrant parents. She said, did you forget every time I complained to you about whenever there was something in the book in school about Black people or slavery, that the class looked at me. Of course, she went to a private school, predominantly white. She said, don't you know I was going through a little bit of depression then? This is 5 minutes ago. And you did not, is now you're listening, you did not listen to me. So I
And
want
you
to
did not.
I want to
Doctor,
appeal. I hated psychiatry. I won't go to classes. I just copied from my friend. So I want to appeal. This is true. Dr. Bujalaye, who died, every Friday he brought his notes to me and I copied it. And I mentioned it last week that's what I did every Friday at 3 o'clock. He brought me his notes. So I want to appeal to parents whose kids are going to these private schools and the child may be the only Black person in the class, second generation, whatever generation, immigrant parents. Please take it seriously because I just got told off when I was listening to it. And I do remember some of the things. And I would say, forget it. I went to Nigeria and I survived. You will survive here. But it's a different culture. And it was 47 years ago I graduated. So I'm old and resilient. But that doesn't happen now.
Dr. Olele, she went to medical school in Lagos.
Mhm.
She went to Medilag, got full scholarship to go. She's Caribbean, but she grew up in Lagos in a medical school, and she would tell me about Mushi and Oshodi and how to handle people. She's incredible, Dr. Buka. So, but on a more serious note, Dr. Buka, you are right on point. I give it over to you, Dr. Lily. I have to tell on her a little bit more. Was why I spoke. Go ahead.
Yeah, Dr. Booker was on point about that, with your children who are first generation in either UK, Canada, there's certain struggles that they're going to, and so sometimes it could be tough when the parents who are like, "Oh, I survived Nigeria or I survived wherever I came from." You should not have that. You should not be depressed. I should be depressed, and so is a different battle that your kids are going through. And we always have in generational, every generation compares themselves to the generation under them and say, "Oh, we got it bad, you got it bad." But sometimes you got to remember that the person that your child is only speaking from what they see and know and their age. And so you're coming to them from wisdom and a life experience, but they are not. And so, in a different environment, because a lot of times you grew up in an environment where it's African, all black. So you saw a black president, you saw a black governor, you saw a black news anchor, you saw black models on TV, you saw wealthy blacks. But here in America, it your child is seen where sometimes black is the media wants to portray any black person as aggressive or angry or not smart, or there's only one black president they've ever seen, very few black governors they encounter. So you're coming from a place where in Africa where it was normal versus here where it is a dream that your kids could see that, or if you, unless they live in a predominantly black community, then they could see that. But everybody has their different thing, and the self-esteem comes from what you could see.
Thank you. Thank you so much. Dr. Aluya, kindly unmute and I don't know if you have a comment or a question, but please follow up with the
Yeah,
subject coming up this month.
it's a question. And I say this because when you guys were talking, it just came to my mind. Because in physical medicine, for instance, um, what do you call it? Multiple myeloma, right? Or what do you call it? What's this other disease? Where we talk about epigenetics, right? Where the environment where you live affect how your body translates or interprets your genetic material. And we know that genetic malformations and affiliations with psychiatric diseases, right? So when you talk about resilience, that's when, I think was it Dr. Jabida was saying that everyone, when somebody moved from Nigeria and moved over here, and it now seems a generation after generation, they lose the resilience. Now, we know that the same diseases, because they moved over here, they developed those diseases, and the age cuts between some of them as well. If you moved here, 15 years or older afterwards, your chances of having that disease, like multiple sclerosis, is much less as compared to if you move here 15 years or younger. So in that case, I was just asking, does that apply also to psychiatry? Have you read or heard anything, in that respect?
I haven't read that, but I could hypothesize it's also dealing with the culture, what you've instilled in with the values, expectations, what was in the household. Because the one of the things I always say is all our brains are different. So based off of what you're able to process, your maturity level, the type of environment you have, 'cause environment means everything. And a lot of people in an African environment, because sometimes you're coming from where resources are limited, you learn how to adapt. And so that's a skill set that is very useful when they come to United States or UK or anywhere, because you know how to adapt. And then
Mm,
also too, like I was saying, environment, when you grew up being in a black environment, like people growing up in the Caribbean, growing up in Africa, Haiti, they're used to seeing black business people, black presidents, black leaders. And so when they come to the United States, they're not thinking from a race standpoint. They're thinking from an economic and educational standpoint. They're like, I'm going to go in and dominate in school. You're not going to stop me, because if I could do this with limited resources and I come here and I have all
mm,
the resources, I'm going to crush it. And so that's why a lot of people from the Caribbean or Africa or Haiti, they come here and they just automatically start dominating because they they see the light. And it's not saying, oh, somebody's African American or white American, they can't do it. But when you come into somewhere where resources are limited, or even you have the mindset that you're not lower than any other race, you're not lower to Asians, you're not lower to whites, that you have the same mind like them, or even better, that you could dominate. So it's a different type of mindset
mindset.
that you get because you've seen it.
Right. Because the question is that does new chemicals form? Because in the brain, you know that, the acetylation and all the different processes that take place with new enzyme formation, new pathways. When you talk about addiction in kids as well, I think sometimes, who knows? Maybe, something will come up and AI will tell us that there are new formations and neurochemical bondings that form when people move from one area to another. Hopefully we'll see that. Thanks.
Yes, you're talking about like neuroplasticity,
Right.
synaptogenesis, where when you're learning new things or new things, these new circuits or connections develop from the brain. And that's what the TMS, what I do, the TMS does. It creates those new pathways or those new circuitry connections.
Right.
Thank you so much. Dr. Aluya, I'm going to revert back to you in a minute. I think Mrs. Fality Nike has been trying to raise up her hands and it keeps going up and down.
No, please.
No?
I
Okay,
wanted to
fantastic.
lower it. Thank
Yes,
you.
it was going up and down. So, Dr. Aluya, before I go back to Dr. Olele, so he can round this up for us, can you please tell us about what is happening July 18?
Uh,
Dr. Aluya.
Thank you. Yes, thank you. Sorry. Let me lower my hand as well. Yes, thank you for the opportunity. I know we talk about, health and other issues and how we preserve and conserve our community. But one of the other things that sometimes often missed in our community is the finances. But not just finances, personal finance, but collective finances. And that's where you talk about economics. So July 18th, like Dr. O had talked about, and I'm glad Dr. O is such an all-rounder, bringing this up. July 18th, myself and Dr. O is involved as well, and a few other people around the community and those in Nigeria putting together an African Ambassadors Economic Forum summit that's taking place July 18th at the Westin Hotel in Washington, D.C. It's going to be a great time, for us to come together, because a lot of us don't know who our representatives are. Those who represent the governments that we so, the countries that we come from and the governments we so wish for the continent. We don't know where they're from, who they are, and they often stay by themselves. So this is an opportunity to bring them all out, meet with those of us in the diaspora, interact with us, hear what they're saying, listen to what they're saying, and see how much we can offer help. Now, the other reason is to potentially create the platform where each and every one of us will meet with one another, interact with one another, see where the resources are. I mean, for instance, if Dr. Olele had not come here today, I would not even know he exists. You understand? And which is a beautiful, now I know, and I can call, if I see his name anywhere else, I may be calling on him. So that's why coming out is important, where we all meet each other, see where the resources that we have. And like some of you have heard me say, um, show me your network and I'll tell you your net worth. But that network is coming out of networking. And that networking, we're putting our resources together. Power is most effective when concentrated. So we need to concentrate the resources we have, but better so deploy it. So that's the platform. And then hopefully we get also the third one, also to get a space where we'll have a think tank community to come up with a possible Marshall Plan for Africa. We see what's happening around the world right now. The globe is on a different scale. We're all here. We're foreigners. Most of us, thank God, we see second generation. But guess what? We don't even know where our children and great grandchildren will live, we still being alive. We don't. They may live in America, they may not live in America. And I'll give you stats. Some of you know I love statistics. 2075. A lot of us may not be there. Some of us will, and our children and grandchildren will. In China will be number one GDP, the biggest economy in the world, followed by India, followed by America, followed by Brazil, and then the number five will be Nigeria. This was Goldman Sachs saying this for the year 2075. Now, they look at this since project. Now, what does that mean for our children as well? Where would they be living? Would they be following the money? Would Africa be big enough? So that's why planning a roadmap for our children so that they see what we are doing so that they can follow. Because guess what? Some people created the roadmap for us to live here today. And I said, Dr. O heard me the other day when I said, when Martin Luther King was saying, I have a dream that children of slaves and slave owners will sit at the table and have the discussion. He was talking probably, not just for his family or for his children or for African Americans. My father was in his village in Isoko land, was a young teenage boy. Now his son is enjoying those dreams that he's living, he talked about. And we're living that dream, you and I and all of us. So what is the dream we're going to think for our children and children's children in the future? Where will they live? What's that roadmap we're going to create for them? So that's that Marshall Plan we're hoping to see. And of course, lastly, talk about Africa 63. Every one of us have heard SDGs, SDG, SDG, SDG. But has any one of us had, and a lot of us are Pan-Africans here, but have you heard about Africa 2063? That's a big plan that was set for Africa for the year 2063. Your children will be living, and they are Black. You understand? So what does that mean? What does that mean to you? How much does it affect you? And a lot of us don't know what it is. So that's why we're having this, program on the 18th. We hope to have a lot of you, come up and see and join. We have the West is giving us a discount of $129 per room, which is so incredibly cheap. Breakfast, lunch, and dinner will be served. There's an award ceremony coming up. So it's all for us. This is yours as well as mine. Let's own it. Let's create a future, another dream for our children and generations to come. Thank you and God bless.
And I will send the information out as soon as you get me the updated information. So
Yes.
send it out to our folks. It's very, very important. It's part of mental health.
Yes, our children's mental health and
Are you going
resilience.
to have Zoom?
No.
Why not?
No.
There'll be no Zoom. It's a paid event.
Why
And
Right.
not?
so
So,
it's a
Because some
paid
of
children,
us
we
will not
want
be
you there.
around.
Well, you make time for the things that are important to you.
it's a paid
No,
event.
I'm already planning to be somewhere else before.
It's a paid event. We'll talk about it.
Well, it's okay.
We'll talk
It's all
about it.
right.
Yeah. But it's a very important one.
Yeah, we'll already be
So
in
I'm going to
Nigeria.
hand over to Dr. Olele to please give us his parting remarks. Thank you so much for your patience and for your education. Oh my gosh, Medical Mondays family, we can stay here till 10 o'clock. So please give us your parting words.
No, thank you for allowing me to speak this evening on a topic that I love to talk about with mental health and educate. Um, Definitely, I would say, um, like you don't have to be a physician or a therapist to be an advocate about mental health. Mental health is in every industry. Mental health is in your job. Mental health is in your household. Mental health is in your church. So uplift others. And if you see somebody down, just say, hey, um go see this therapist or this psychologist and you could get help. And I'll put into the chat group, there's a thing called Psychology Today as well, where you'll be able to type in your zip code and you could find a psychiatrist or therapist and you could just look and they'll tell you if they're culturally competent or whatnot. So definitely do that. I'd love to be a resource if you connect with me online or anything. And if I don't have the answers, I can always point you to somewhere. And be on the lookout. I'll let Dr. O know about my upcoming book coming out soon. So it'll talk about wellness strategies for you all. And so I will share with her once the book is officially out, and she could share with you, because it's going to be a very powerful book. And a lot of the concepts we talked about here, such as spiritual wellness, environmental wellness, occupational, financial wellness, it is discussed in this book and how it applies to your health. And I hope for you and your families to prosper, and then definitely you coming here shows that you want help and you want to be knowledgeable. So God bless your Medical Mondays community, and God bless your families.
Amen. Amen. Thank you so much. We'd like to bring you back and launch that book here
Okay.
on Medical Mondays with Dr. O. And thank you for taking the time to even do it, to write it. Thank you for caring so much about us. God bless you. Thank you.
Bye, everyone.